MidCental District Health Board about a year ago was made aware of some new data that was measuring newborn enrolment at general practice level. We realised very early in the piece that there was a complete mismatch of the data. The ministry data was telling us 60% of our kids were enrolled at 3 months of age. General practice were telling us that we thought about in the 90s. We knew we had high 96% immunisation rates, so it didn't equate. And so we embarked on a journey to try and figure out what that mismatch was, what it looked like, what were the components of it, and could we rectify it? Because, you know, we knew eventually with system level measures that general practice was going to be, there was going to be a portion of remuneration that was, you know, accompanying this, and we needed to have the data right.
Initially we started by doing a driver diagram to identify all the factors that can impact on determining whether a baby's enrolled with a general practitioner or not. So we looked at things that were happening within general practices themselves, what was happening here at the PHO and with the newborn enrolment team, and really starting to think about what were some of those easy, quick win things that we could do and implement and measure that would have an impact. We were able to monitor our rates of newborn enrolment, but as Barb's identified, those rates weren't coming through with the ministry's data.
We knew the PHO had some of the data, our maternity systems had some of the data, and the immunisation register had some of the data. And so by getting it all together in one place, which I could then manipulate, we could find out exactly who our population was, who was enrolled and who wasn't.
I'm working with the doctors, the midwives, newborn hearing screening, adolescent oral health, all the well child providers, making sure that all the babies have been enrolled with the different provider that they've selected, working on the relationships with all those people because it all comes together, you know, for the benefit of the baby.
Having those early relationships with a general practitioner, really, really critical.
12 months into the project, we've done quite a lot of work around the data aspects of it, so ensuring the quality of the information that we're sending off to the Ministry of Health. Also, we're providing much greater feedback to the practices. So from a success point of view, that's probably the largest thing that I could identify anyway. It's very difficult for practices to improve something if they don't know what to improve. So the quality improvement cycle in this case is feeding back the information to general practice. They can then change their process such that it improves the final outcomes. Yeah.
The first round of PDSAs we undertook was looking at the way Michelle's notifying general practices of new babies being born, and she was doing that with a weekly fax list, and she was finding that she wasn't getting, all the babies weren't being enrolled, and she wasn't getting the kind of feedback that she was hoping to get from practices. So she did a couple of things. One, made some calls to some practice managers to really hammer home the importance of enrolment, and then we looked at communicating the processes for correctly enrolling babies in a practice, and we approached a practice that we knew was doing a really good job and asked if we could use their procedures and grab their gold standard of what they do, and then we were able to share that with other practices through the infographic. We did a small test of the impact of that infographic by developing it up and then sharing it amongst the team and getting feedback on that, making it simple and easy to read, and then sending that out to practices. So that's just gone out and we haven't yet got the data back on the impact of that, but we've been able to look at the rates of GP nomination over the past 6 months, and that's increased significantly.
The procedures that make up PDSA, it's been really useful in that we can use that in our own timeframes because we can make changes and we can see what happens with those changes using our own monitoring rather than ministries, and then use that to make further improvements or to look for other changes that we can make.
When we started this journey, we were all a bit like, you know, driver diagrams, flow charts, improvement methodology. We were all a bit spooked by it, to be honest. But honestly, it's becoming a way of the world here. You know, we've got clinicians saying, oh, let's just do a quality improvement cycle on that. Let's see, you know, and everyone's just got the hang of it, and it just makes life so much easier. The communication between our teams, the relationships have strengthened.
It's a continuous quality improvement cycle, so it's not just sort of start and finish it. We go back and look at it again.
Yeah.